our introduction for myocardial disease. Next slide. We have two disease category referred for the myocardial and myocardial disease. We have either myocarditis or cardiomyopathy, are diseases that primarily affect the heart muscles. So, what is the myocarditis? Next slide. Myocarditis is acute or chronic inflammatory pathology of the myocardium. It's referred as myocarditis. While idiopathic myocardial disease is referred to as cardiomyopathy, and we have several types of both of diseases that we will discuss later on. Next slide. To start with myocarditis. Myocarditis is acute myocarditis is acute inflammation of the myocardium. It has many causes. It may be idiopathic or infective causes. Infective causes like viral, like Coxsackie virus, and recently discovered the coronavirus, even one of the important causes of the myocarditis. I see several causes of acute myocarditis related to COVID, and other viral infection may cause myocarditis like CMV, eco, influenza, polio, hepatitis, and HIV. Parasitic infection like Trapaceoma cruzi, Toxoplasma, bacterial infection like Streptococcus, spirochetal disease like Lyme disease, and leptospirosis. Even fungal infection and rickettsia may cause myocarditis. Third important cause is toxin and drug, causing hypersensitivity reaction like methyldopa, antituberculous, modafinil, ethanol, cocaine. Also radiation may cause myocarditis, and finally autoimmune disease like SLE and sarcoidosis and vasculitis in general. This is the important causes. From this list of causes, the most important one is viral disease and autoimmune disease and toxin and the drug which occur, for example, post-chemotherapy. Next, please. The causes of myocarditis categorized into table. Next slide. Pathology. What occurs in myocarditis? In acute phase of myocarditis, the heart is floppy with focal hemorrhages. In a chronic case, the heart is enlarged and hypertrophied. Histologically, the inflammatory infiltrate, with lymphocytes predominate in viral causes and polymorph predominate in bacterial causes. Next slide. How the patient comes to the doctor. What is the clinical feature of myocarditis? It may be an acute or chronic presentation. The clinical presentation ranges from asymptomatic state associated with limited and focal inflammation to fatigue, palpitation, chest pain, and shortness of breath, to more severe cases present with fulminant congestive heart failure, with generalized body swelling and exertional dyspnea due to diffuse myocardial involvement. Next slide. What we will see on physical examination. In physical examination, we can see soft muffled heart sound, a prominent third heart sound and galloping rhythm if there is tachycardia, and even may hear pericardial friction rope, and even may hear other murmurs of functional MR or functional TR. Next slide. Investigation. On investigation, on chest X-ray, we see cardiac enlargement. ECG may demonstrate non-specific ST and T wave abnormalities and even arrhythmia like ventricular tachycardia. Cardiac enzyme like troponin is elevated. Echocardiography help evaluate the cardiac function, and in case of congestive heart failure, we see dilated LV and RV with low ejection fraction and pulmonary hypertension, and even echocardiography is important to exclude original wall motion abnormality which occur in ischemic heart disease and primary cardiac causes. Cardiac MRI have improved the visibility of the myocardium, and in advanced cases we may resort for endomyocardial biopsy to demonstrate the inflammatory cell infiltrate, and viral RNA can be measured from biopsy material using PCR. Next slide. Treatment is the treatment for underlying cause if present. For example, removal of drug and toxin like ethanol or cocaine, or chemotherapeutic agent, or treatment of SLE. Bed rest is recommended, and standard management of heart failure is indicated. For example, use of diuretic, ACE inhibitor, and beta blocker, spironolactone, plus minus digoxin. Next slide. Use of corticosteroid is controversial. There is no evidence of any benefit from treatment with corticosteroid, but there may be benefit in cases of COVID myocarditis with hypoxia. Novel antiviral immune modulating agent like, for example, gamma interferon interleukin may be available in future for treatment of viral myocarditis. Other form of myocarditis. Next slide. We have giant cell myocarditis and Checkers myocarditis. Giant cell myocarditis have rapidly progressive course and poor prognosis, and even immune suppression may be indicated due to infiltration of multinucleated giant cell within the myocardium. May be associated with sarcoidosis and thymoma and autoimmune disease, while Checkers disease or caused by protozoan disease, Trypanosoma cruzi, it's endemic in South America and may present with acute or chronic heart failure. Next slide, please. Now we talk about other form of myocardial disease, which is cardiomyopathy, are a group of disease of myocardium that affect the mechanical or electrical function of the heart. They are not secondary to coronary artery disease, hypertension, or congenital or valvular or pericardial abnormality. So, cardiomyopathy, when there is diseases of the myocardium that are not secondary to coronary artery disease or hypertension or congenital or valvular or pericardial abnormality. For that reason, they are called primary myocardial diseases. They are frequently genetic and may produce inappropriate ventricular hypertrophy or dilation, and can be primarily a cardiac disorder or part of multisystemic disease. We have four main types of cardiomyopathies. Next slide. Dilated, hypertrophic, restrictive, and arrhythmogenic right ventricular cardiomyopathy. The most common form of this disease is dilated cardiomyopathy. Next slide. In this slide, we see the hearts. In the graph A, we see a normal heart. In graph B, we see hypertrophic obstructive cardiomyopathy. We see focal asymmetrical septal hypertrophy. In graph C, we see diffuse hypertrophy of the symmetrical hypertrophy of the alveoli. In graph D, we see apical hypertrophy, in which the hypertrophy affects only the apex of the left ventricle. In graph E, we see dilated cardiomyopathy, in which the dilation of both the alveoli and RV. In graph F, there is arrhythmogenic right ventricular cardiomyopathy, in which there is only dilation of the right ventricle. In graph G, there is restrictive cardiomyopathy. Next slide, please. Now we talk about dilated cardiomyopathy. Dilated cardiomyopathy is dilation of an impairment of contraction of left ventricle and sometimes the right ventricle. The LV mass is increased, but wall thickness is normal or decreased. Histologically, there is myofibrillary loss. Incidence is 20 cases per 100,000. Men are affected more than twice as often as men, and most of the cases are young. 25% it is familial disease. I have a family in Najaf. I have a family in Najaf with dilated cardiomyopathy occurring at the second decade of life, affecting and run in the family in autosomal dominant pattern. Sporadic dilated cardiomyopathy can be caused by multiple conditions, for example, myocarditis, toxin, autoimmune, endocrine, and neuromuscular disorder. Next slide. How will the patient present? It presents with heart failure, with exertional dyspnea, and if congestive body swelling, and with cardiac arrhythmia, for example, AS or VT, with conduction defect, for example, heart block, with thromboembolism, for example, stroke, acute limb ischemia, or even sudden cardiac death. Sporadic chest pain is a surprisingly frequent symptom. Evaluation of relative of dilated cardiomyopathy patient, allowing the identification of early asymptomatic disease prior to onset of complication. Investigation. Chest X-ray will show cardiac enlargement, ECG non-specific STT wave changes, echo is a standard for diagnosis, and reveal dilation of left and or right ventricle with global poor contraction. This should be differentiated from regional poor contraction. Regional poor contraction or between two brackets, regional wall motion abnormality is seen in ischemic heart disease, but global wall motion abnormality or global poor contraction is seen in dilated cardiomyopathy. Cardiac MRI is important. Coronary angio should be performed in every patient more than 40 years of old to exclude ischemic heart disease. Next, the treatment is the treatment of standard heart failure. And the disease progression is even slowed by the use of ACE inhibitor and spironolactone together with beta blocker. The ventricular tachycardia is best treated with implantable cardiac defibrillator, anticoagulation if there is AF or history of embolization, and severe cardiomyopathy refractory to medical therapy is the indication for cardiac transplantation. Next slide, we talk about hypertrophic cardiomyopathy. It is common disease with a prevalence about 100 case per every 100,000, characterized by marked inappropriate ventricular hypertrophy in the absence of any alternative cause. And most important to diagnose hypertrophic cardiomyopathy is to exclude aortic stenosis and hypertension, which cause a pressure overload and left ventricular hypertrophy. Another important difference is that hypertrophic cardiomyopathy may be present as asymmetrical hypertrophy, which is maybe generalized or confined to interventricular septal or to the apical region, as we see in the graph. The pathophysiology of the condition in which there is stiff myocardium, so stiff left ventricle will cause diastolic dysfunction and impair diastolic filling, and later on stroke volume is reduced. Septal hypertrophy also may cause left ventricular outflow tract obstruction and is referred to as hypertrophic obstructive cardiomyopathy. And even septal hypertrophy may cause mitral regurgitation due to abnormal systolic anterior mitral valve motion. It is referred to as SAM. Most cases are familial, autosomal dominant, and caused by mutation in the gene coding for a protein that regulates the contraction, for example, troponin and beta-myosin. Next slide. Clinical representation of hypertrophic cardiomyopathy may present as asymptomatic and detected through family screening of the affected individual or following routine ECG examination. At present with chest pain, shortness of breath, syncope, pre-syncope, especially exertional syncope, and even cardiac arrhythmia and sudden cardiac death, especially in the athlete or sportsman. Next slide. Signs. On examination, we see double apical pulsation due to forceful atrial contraction producing a fourth harsh sound. Jerky carotid pulse because of rapid ejection and sudden obstruction of left ventricular outflow during systole. Ejection on auscultation, we may hear ejection systolic murmur due to left ventricular outflow obstruction in the late systole, and even pansystolic murmur due to mitral regurgitation, and even fourth harsh sound due to active atrial contraction if the patient not in atrial fibrillation. The ECG, next slide, in hypertrophic cardiomyopathy, we demonstrate left ventricular hypertrophy with ST and T wave changes and abnormal Q wave, especially in the inferior lateral lead. Echocardiography is usually diagnostic, and in the classical hypertrophic cardiomyopathy, there is asymmetrical left ventricular hypertrophy. It means that the interventricular septum is hypertrophied disproportional to the degree of hypertrophy of the LV posterior wall, with systolic anterior motion of the mitral valve, mitral regurgitation, even may be demonstrated. Cardiac MRI also is important, and genetic analysis, where available, may confirm the diagnosis. Next slide. Treatment of hypertrophic cardiomyopathy is treatment of symptom and prevention of sudden cardiac death in patient and relative. Beta blocker and rate-limiting calcium antagonist, verapamil, and disopyramide can help to reduce symptom and sometimes prevent syncopal attack. LV, left ventricular outflow tract obstruction, can be improved by surgery, myectomy, or by alcohol septal ablation using catheter-delivered alcohol solution. Digoxin and vasodilator should be avoided, and ICD should be considered in patients at a clinical risk factor for sudden death. Risk factors for sudden death are massive LV hypertrophy more than 30 mm on echo, family history of sudden cardiac death, non-sustained VT, unexplained syncope, abnormal blood pressure response to exercise, and family members should be screened to prevent the onset of sudden cardiac death. Restrictive cardiomyopathy, next slide. In this condition, the ventricular pharynx is impaired due to ventricles are stiff, lead to high atrial pressure with atrial hypertrophy, dilation, and later on atrial fibrillation. It is a rare condition and most commonly caused by, next slide, amyloidosis. Other form of infiltration, for example, glycogen storage disease and idiopathic perimyocyte fibrosis. A presentation, how present? It will usually present with, next slide, present with symptom of heart failure, for example, dyspnea, fatigue. Embolic symptoms are a presenting feature sometimes. Next slide. The clinical features or physical signs of restrictive cardiomyopathy are similar to reconstructive pericarditis. It leads to high jugular venous pressure with diastolic collapse, called Frederick's sign. Also, there is elevation of venous pressure with the inspiration, or called Kussmaul sign. S4 is common, and S3 may present in advanced disease. In idiopathic restrictive cardiomyopathy, cardiac size may remain normal, and it is one of the causes of heart failure with normal size heart on X-ray. Next slide. Investigation: chest X-ray may show pulmonary venous congestion. The heart may be normal or show cardiomegaly or atrial enlargement. ECG may show low voltage and ST segment changes. Echocardiography show symmetrical myocardial thickening and often normal systolic ejection fraction, but impaired ventricular filling, or it's called diastolic dysfunction. Cardiac catheterization is important for diagnosis. Endomyocardial biopsy may have a role for diagnosis. Next slide. In restrictive cardiomyopathy, treatment is difficult and the prognosis is usually poor, and cardiac transplantation may be indicated in severe cases, especially the idiopathic variety. Next slide. The final form of cardiomyopathy is arrhythmogenic right ventricular cardiomyopathy. In this condition, patch of right ventricular myocardium are replaced with fibrous and fatty tissue, and that lead to, next slide, arrhythmia and sudden cardiac death. The disease is inherited in autosomal dominant trait, and the management of this disease is through the insertion of implantable cardioverter defibrillator and even cardiac transplantation and treatment of arrhythmia. We have a specific form. Next slide. Specific form of cardiomyopathy is called peripartum cardiomyopathy. Peripartum cardiomyopathy is a form of dilated cardiomyopathy occurring during the last trimester of pregnancy and even in the early postpartum period, and present with symptom of heart failure. Next slide. Now we talk about the disease of the major vessels or disease of the aorta. We have aortic aneurysm, aortic dissection, and aortitis. Next slide. In figure A, we see here a form of aneurysmal abdominal aorta with a thrombus below the origin of renal artery. In the figure A, in the middle of the graph, we see dilated ascending thoracic aneurysm due to Marfan disease, while in the furthermore image we see compression of the bronchus by main saccular thoracic aneurysm. In the bottom of this slide, we see aortic dissection. We have two forms of aortic dissection that we will discuss later. Aortic dissection is type A if it is involved the ascending aorta, and is type B if it is involved the descending aorta. Next slide. Aortic aneurysm, abnormal dilation of the aortic lumen. A true aneurysm involves all layers of the wall, whereas false aneurysm does not involve all layers. Why aortic aneurysm occur? Next slide. Either due to non-specific causes, idiopathic, or due to Marfan, or due to aortitis, or due to thoracic aortic aneurysm, and the classification of the aneurysm into thoracic and abdominal aortic aneurysm. Abdominal aortic aneurysm affects 55% of men above the age of 60. Next slide. And 80% are confined to the inferior infrarenal segment, that is below the level of origin of renal arteries from the aorta. Usual age of presentation is at elderly, and diagnosis by ultrasound or CT scan of the abdomen. Next slide. Common presentation for abdominal aortic aneurysm, incidental finding on ultrasound or imaging, and may cause abdominal pain, may cause thromboembolic complication, may cause compression on surrounding structure, or may rupture and present as cardiogenic shock and intraperitoneal bleeding, retroperitoneal bleeding. Next slide. Management is to give beta blocker and send the patient for vascular surgery for surgical repair. Next slide. Aortic dissection. Aortic dissection is when the wall of the aorta have been separated and there is active bleeding inside the wall of the aorta, producing a false lumen. Risk factor for aortic dissection is hypertension in 80% of cases, aortic atherosclerosis, non-specific aortic aneurysm, even a risk factor for dissection, collagen vascular disease, for example, Marfan, and fibromuscular dysplasia, previous aortic surgery, pregnancy, trauma, and even iatrogenic due to cardiac catheterization. Next slide. هذا سلايد حكينا عنه قلنا bottom of the slide, figure B, we have two types of aortic dissection. That aortic dissection involved the ascending aorta and نسميه type A. The aortic dissection involved only the descending aorta and نسميه type B. The presentation matter of the aortic dissection with severe catastrophic chest pain and plus minus cardiogenic shock, and the treatment with beta blocker and vascular support and surgery is a definitive management. Pericardial disease. Next slide. Pericardial disease. We know that pericardium is, as we said in the first lecture in our series, pericardium is a protective covering of the heart and consists of two layers. How the visceral layer and parietal layer, and in between there is a pericardial, some pericardial fluid that are less than 50 cc of pericardial fluid in normal heart used for lubrication. Presentation of pericardial disease include acute pericarditis and constructive pericarditis and pericardial effusion and pericardial tamponade. Next slide. Acute pericarditis refers to inflammation of pericardium. Classically, fibrinous material is deposited into pericardial space together with inflammatory cell infiltrate. And acute pericarditis has numerous etiology, for example, viral and even idiopathic or even autoimmune and even post-chemotherapeutic agents. Sometimes we have a category of disease named Dressler syndrome. Dressler syndrome is post-myocardial infarction pericarditis. It is one of the autoimmune complications of following MI, occur in 20% of patients, and produce a specific type of chest pain different from the chest pain of the myocardial infarction. Pericarditis may also occur in the recovery phase after the infarction. And pericarditis also may occur in chronic kidney disease or uremia. It is referred to as uremic pericarditis due to irritation of the pericardium by accumulating toxin. Occur in 6 to 10% of patients with advanced renal failure if dialysis is delayed, and it is an indication for urgent dialysis as it continues to be associated with significant morbidity and mortality. Next slide.
إذا عجبت شو الوضعية تطفي المنبهات منطمرة مواتي.
Also, we have another form of pericarditis. It's bacterial pericarditis, or even tuberculous pericarditis, fungal pericarditis, and malignant pericarditis due to infiltration with malignant cell. And sometimes pericarditis occur following Hodgkin lymphoma, in which there is most infiltration of the pericardium with lymphomated cell. Next slide. هذا السلايد يوضح لنا الكوزز اوف pericarditis اللي حكيناها قبل شوية. ف next slide. How present the pericarditis. Pericardial inflammation produces sharp central chest pain, different from the ischemic chest pain. Here the chest pain is sharp, but in the ischemic chest pain we have dull arcing chest pain, burning chest pain. But in pericarditis it produces sharp central chest pain exacerbated by movement, respiration, and lying down. The main differential diagnoses are angina and pleurisy, and the classical sign on auscultation of the heart is pericardial friction rub occurring in the free phase corresponding to the atrial systole and ventricular systole and diastole, and also may be associated with fever, leukocytosis, lymphocytosis, when pericarditis is due to viral or bacterial infection. Sometimes feature of pericardial effusion may also present. Large pericardial effusion can compress adjacent bronchi and lung tissue and may cause shortness of breath. Next slide. Investigation. The ECG is diagnostic. There is a concave or saddle, concave upward, saddle-shaped ST elevation. The PR interval depression is a very specific indicator for acute pericarditis. These changes evolve over the time with the resolution of ST elevation. This ST elevation should be differentiated from the ST elevation due to myocardial infarction. Here the ST elevation is concave upward, but in myocardial infarction is convex upward. It must be differentiated from the myocardial infarction because the management is completely different. Cardiac enzyme should be assayed, as they may be elevation if there is associated myocarditis. Chest X-ray, echo, and radionuclide scan are of little value in uncomplicated acute pericarditis. Treatment. If the cause is found, it should be treated. Otherwise, bed rest and oral non-steroidal anti-inflammatory drugs, for example indomethacin or naproxen, can be used. In a few days following myocardial infarction, NSAID use associated with high rate of myocardial rupture, and this drug should not be used. So NSAID should not be used in post-MI pericarditis. Corticosteroids can be used when the disease does not improve rapidly, and especially in cases of viral or autoimmune or connective tissue diseases. And numerous other treatments have been studied, including azathioprine, colchicine, intravenous corticosteroid, and pericardectomy. Current data tend to favor the use of colchicine to prevent further attack of pericarditis. If pericarditis persists for more than 6 to 12 months following the acute episode, it is considered as a chronic. If the pericardium is thickened and there is the ventricular filling, constrictive pericarditis is said to have developed. Pericardial effusion and tamponade, in which there is collection of the fluid within the potential space of serous pericardial sac that accompanied episode of acute pericarditis, and when this fluid collects under pressure, a pericardial tamponade is said to be occurred when there is embarrassment of the right ventricular and left ventricular function. Clinical feature of pericardial effusion commonly reflect the underlying pericarditis. So, and in addition to heart sound are soft and distant, apex beat is obscured, friction rub may be evident, and the base of left lung producing an area of dullness to percussion below the angle of left scapula, aortic sign. And as the effusion worsens, signs of cardiac tamponade may become evident, with raised jugular venous pressure and inspiratory drop in JVP during the inspiration. It is called Frederick sign or Cosmal sign. Pulsus paradoxus and reduced cardiac output. Investigation: ECG show low voltage QRS complexes in patients with pericardial effusion. Chest X-ray show globular, large, pear-shaped heart with sharp outline, and pulmonary vein are not distended. Echocardiography is the most useful technique for demonstrating effusion and looking for evidence of tamponade. Also, MRI may be indicated, and pericardiocentesis is the removal of pericardial fluid with aseptic technique under echocardiographic guidance. It is indicated when tuberculous, malignant, or purulent pericardial effusion is suspected. Pericardial biopsy may be needed if the TB is suspected and pericardiocentesis is not diagnostic. Next slide. The treatment of underlying causes is important and should be treated if possible, and most pericardial effusion will resolve spontaneously. However, when the effusion collects rapidly and there are features of tamponade, pericardiocentesis is indicated. Pericardial effusion may reaccumulate, most commonly due to malignancy, and may require pericardial fenestration, that is, creation of window in the pericardium to allow slow release of fluid into the surrounding tissue. This procedure may either perform transcutaneously under local anesthesia or using conventional surgical approach. Next slide. Now, the end sequel of every chronic pericarditis or recurrent pericarditis is the constructive pericarditis. It occurs as a complication following TB or hemopericardium or bacterial infection and rheumatic heart disease. The result in pericardium becomes thick, fibrous, and also following post-cardiac surgery. In many cases, these pericardial changes do not cause any symptom. However, a pericardium becomes so inelastic to interfere with diastolic filling of the heart, constructive pericarditis is said to be developed. As these changes are chronic, allowing the body time to compensate, this condition is not as immediately life-threatening as cardiac tamponade, in which the accumulation is more acutely embarrassed, in which the circulation is more acutely embarrassed. Constructive pericarditis should be distinguished from restrictive cardiomyopathy. The two conditions are very similar in their presentation, but the former is usually fully treatable, whereas the most cases of later are not. In the later stage of constructive pericarditis, the subepicardial layer of myocardium may undergo fibrosis, atrophy, and calcification. Clinical presentation. The symptoms and signs of constructive pericarditis occur due to reduced ventricular filling and pulmonary venous congestion. So it produces symptoms of reduced cardiac output with fatigue, hypotension, and reflex tachycardia. Atrial fibrillation occurs in 30% of cases. Next slide. Investigation. Chest X-ray show relatively small heart in the view of symptom of heart failure. Here is one of the differential diagnoses of small heart with feature of heart failure. Pericardial calcification is present in up to 50% of cases. ECG show low voltage QRS complex. Echocardiography shows thickened calcified pericardium. CT and MRI are used to assess pericardial anatomy and thickness. Endomyocardial biopsy may be helpful in distinguishing constrictive pericarditis from restrictive cardiomyopathy, and even cardiac catheterization may be indicated. The treatment of chronic constrictive pericarditis is complete resection of pericardium. This is a risky procedure with high complication rate due to the presence of myocardial atrophy in many cases and risk of myocardial damage. Thus, early pericardectomy is suggested in non-tuberculous cases before severe constriction and myocardial atrophy have been developed. In case of tuberculous constriction, the presence of pericardial calcification implies chronic disease. Current evidence tends to favor early pericardectomy with antituberculous drug cover in these cases. If there is no calcification, a course of anti-TB therapy should be attempted first. If the patient's hemodynamic state remains static or deteriorate after 4 to 6 weeks of therapy, pericardectomy is recommended. This is the end of our lecture. I am glad if there's any, if I hear any questions.
شكرا جزيلا دكتور. دكتور لحد الآن ماكو سؤال، بس شوي ننتظر إذا أكو أحد يكتب سؤال بالشات.
إن شاء الله.